see so many of us here in person. And I think that SAGES really is what SAGES is about. SAGES is that really at that sweet spot, the intersection of surgical innovation and education. And I mean, it's pretty obvious, but operating is what differentiates us from other physicians. And we're all here because we spend a lifetime really perfecting our surgical skills. And of course, I see some of our great residents here, and I remember, and we all remember, that obviously the steepest part of that learning curve occurs during our formal training, residency, and fellowship under supervision. If you're lucky, under supervision of very patient people like Dr. Fried here, where we receive a lot of continuous feedback, and our techniques evolve and are refined over time. And this is, I think, a fantastic meeting. I'm a tiny bit biased, but I think it's a fantastic meeting. And a lot of what makes SAGES such a great meeting, I think, and what draws many of us to SAGES is that a lot of the sessions are really about how to do surgery. They're about surgical techniques and the pearls and the tips and tricks and perfecting those surgical techniques, how to gain that mastery and that expertise. And wow, it takes a really long time to get through that learning curve. Just like a really simple example, a common procedure, laparoscopic inguinal hernia. We know from literature that it takes over 200 cases for TEP before the recurrence risk is around the same as for open cases. And really maybe even 400 cases until that improvement plateaus. That's a really long time, 400 cases, for some common procedure like that. Yet for all of us surgeons in practice, quality improvement efforts have largely ignored performance of the operation itself. And part of the reason for that is because it's been pretty difficult to study what happens in the operating room, and it's remained something of a black box. But clearly that's changed with the advent of image-based surgery like laparoscopic or robotic surgery, and that's made it pretty easy to record cases. Although we haven't had easy ways to really easily store, access, and analyze those videos until recently. And we continue to learn surgery as a craft, basically through our apprenticeship. And part of that is technical skill, no question, but a lot of expertise is related to these really complex cognitive schemas that are repeatedly seeing patterns over time and building up those kind of complex cognitive schemas that allow us to predict what's going to happen next, and that are created over time. And we experience that. We can experience that in the operating room when we're with our more junior learners or colleagues, and they just, they don't see what you see, that you see that instantaneously, and even if they're really good technically and can do that peg transfer task in 20 seconds, and there's no, tremor for the grasper to get to the trauma of Callot, but they're just not necessarily going in the right place. And for you, it's, and I remember being the resident and saying to one of my mentors, how did you know that you could put the Maryland right there and that was safe? And he was like, I don't know, I just know. And we have increasing data that surgical performance is related to outcomes, and that's not really, it wouldn't be a surprise to anyone, at least for safety outcomes. This is just an example. One of our research residents, Saba Balvardi, did this systematic review, and I think we're all familiar with the Berkmeyer study, landmark study in the New England Journal that related, a very simple measure of surgical skill from video to their large Michigan database, and were able to, in a very elegant, simple study that I'm sure many people wish they had the foresight to have performed, that they found that, that very simple measure of surgical skill correlated with patient outcomes, safety outcomes like complications, reoperation, readmission, ED visits, so those kind of hard outcomes. And it correlated with a stronger association than years in practice or fellowship training or the number of cases that you do a year. And if you look at those videos, like good case, not so good case, you see it right away. It's not difficult. And we found a number of other studies since then, about 10 studies since then, that almost all of them confirmed that association between operative performance and short-term outcomes like complication, and some of them even showed an association with better quality pathologic specimens in colon and rectal surgery and one study's even shown a difference in cancer survival. So this relationship between intraoperative performance and outcomes has several important implications. It certainly suggests an opportunity to provide focused coaching to improve performance based on video, to set benchmarks to confirm competence prior to independent practice, to determine the best techniques that are associated with better outcome. So we all know that. Everybody tweaks an operation that they learned in training, and they make it their own, and they have their own little tweaks based on their experience or based on things that they've seen, and no two surgeons really do anything exactly the same way. There are core principles that I think have come out in our work at SAGES in developing video-based assessments that are key. But then when you see videos and these are expert surgeons, they all do it a little bit differently. So determining what are the techniques that actually make a difference. And eventually to provide point-of-care decision support, maybe through automated computer vision algorithms. And clearly the ability to easily record, store, and access recorded procedures and link this to other data about patients has the potential to really break down what aspects of surgical technique are related to better outcomes, which could then inform upstream decision-making that we make with patients. I think, and that's this idea that we have a lot of data on patients throughout the perioperative trajectory and methods for accessing that data, but it's about linking that all together and then eventually using ultimately outcomes, including patient-reported outcomes or other outcomes of effectiveness to link that back to our decision-making upstream. And by linking this all together, I think that will drive the future of surgery, data-driven interventional healthcare, and helping to drive that from the past where minimal knowledge and equipment and treatment based on basically local traditions to where we are now, which is we have lots of information on each patient, lots of devices for performing and monitoring procedures. And as individual teams, we make the best use of our knowledge, experience, and even judgment, of course, to make decisions on individual patients. But the future is this automated processing of all the available data, interconnecting from globally millions of data points to really become a data-informed profession in procedural specialties. So I think we're going to hear many aspects, a little bit deeper into some aspects of that. I wanted to introduce that as setting up the other sessions, the other talks that we hear about in the session, and I look forward to hearing those with you and hearing some of the discussion. But thank you for joining us today.